Hello, everyone, and welcome to today's webinar focusing on patient and family engagement and partnership in the time of pandemic. I see lots of good friends and new acquaintances introducing themselves in the chat box. Please feel free to add your own introductions there so that everyone knows who's on the line from coast to coast to coast. Si vous voulez entendre en français aujourd'hui, veuillez composer le nombre en rouge sur l'écran et identifier le numéro de code qui est là aussi. I would like to begin by acknowledging that I'm joining today, and as are many of us, from land that has been inhabited by Indigenous people since the beginning. Today I personally am in Ottawa, traditional unceded territory of the Algonquin and Anishinaabe peoples, and we recognize and deeply appreciate their historical connection to this place, as well as that of First Nations, Inuit, and Métis peoples in the various places that people are calling from today. We're thrilled to have more than 400 registrants for today's call, including people right from across the country, as you can see in the chat box from those who are introducing themselves. And I'm delighted to be able to introduce you to all of those who will be speaking on today's webinar. So my co-host, Julie Drury, who is on screen. Julie, wave. There you go. Thanks. Is Strategic Lead of Patient Partnerships here at CFHI, the Canadian Foundation for Healthcare Improvement. On the East Coast, Margaret Melasson, who is VP of Quality and Patient-Centered Care for Horizon Health Network in New Brunswick. Margaret, can you wave so people know who you are? Thanks. And then moving westward, we come to Kingston. So Angela Morin, who is co-lead for Patient and Family-Centered Care at Kingston Health Sciences Centre. And last but certainly not least, Alex Munter, CEO of the Children's Hospital of Eastern Ontario. There we go. And that is your illustrious panel for today's call. I'm going to begin by just introducing the subject of our call and why we're here today. Then I'm going to hand it over to Julie to provide a quick overview to set the stage for our conversation, and then we're all jumping in as panelists. And I would encourage all of you as well on the line, feel free to add questions, comments into the chat box. The chat box will be bilingual, so we'll be translating back and forth. So let me begin by also acknowledging that this is really an unprecedented time. An unprecedented time for us as individuals, and certainly for the health system across the country as well, and in fact right around the world. I want to begin by thanking everyone who is working so very hard to keep everyone healthy and safe, and to make sure that we can all do the very best that we can in these difficult times. And speaking of difficult times, I also want to acknowledge, particularly for all those who are joining us from Nova Scotia today, the absolutely dreadful events from over the weekend. My mother was a public health nurse in Nova Scotia, and so we visited there often as a child, and the trust and openness of communities in Nova Scotia is something that I take with me and carry in my heart. And so sending pieces of that heart to all of you today and all those affected. And, you know, with those multiple different waves that are hitting us in the stormy waters that we're currently in, you know, it's important to think about what's changing and what's not changing. And one of the things that's not changing, I think, is the real importance of resilient health systems and leadership, and the importance of continuing our focus on improvement with and for more people, improvement that lasts and that endures in difficult times like these. And so that's really been, for the Canadian Foundation for Healthcare Improvement, at the core of what we have been thinking about, both pre-pandemic and during and beyond, and thinking about how do we make sure that we're adding value and not noise in these very challenging times. Of course, there's some things for immediate response, but also asking the question not about, because gosh knows it's not, is it over yet or when will it be over, but rather where do we go from here? How do we move forward in the ways that make sense for all of us across the country and that will get us to the kind of care and support that we're all looking for? And so really that's partly where today's webinar comes in. It's the first in our new Spotlight series, bringing people who are dedicated leaders in innovation and improvement to talk about the important topics and challenges that we're all facing. And how do we help navigate those challenges? How do we think about coming together, maybe virtually right now, but coming together in new ways to be able to deliver on the promises and the values that we all have? And so we'll be bringing perspectives like we are today on patient and client-centered care and partnerships and opportunities. We'll also be looking at questions like how do we activate other levers of health system improvement, things like building organizational capacity, engaging frontline teams and managers in improvement. How do we ensure supportive policies and systems that allow us to do this work, that make the right thing to do the easier thing to do? And how do we also promote evidence-informed decision-making as we move forward? And so in that context, our focus today is on family and caregiver presence and patient partnerships during the pandemic. The time of fast decisions when they're imperative, the time when we're all focused on infection control and prevention, and also a time where we need to focus on what we know are some of the fundamentals of good care and good systems. And that includes patient and family partnerships. So Julie, with that, I'd like to turn over to you to start us off for today.
Thanks so much, Jennifer. I'll just give our producers a moment to get our slides up on screen. Great. So, Jennifer, thank you so much for that introduction. And I also want to acknowledge our friends and our colleagues who are joining from Nova Scotia. I'm a native Blue Noser and born and raised in the Maritime. And Maritimers do a really great job of sticking together, and community is so powerful there. So all of our thoughts are with you in Nova Scotia right now. We're talking today about what is patient, family, and caregiver presence and partnership in care. And very specifically, what is the role of family and caregivers as partners in care? And so I want to start off with this slide of setting out, first of all, the importance of the lexicon that we're using right now. We're hearing a lot in the healthcare space about restrictive visitor policies. And I think that is not necessarily resonating with our family caregivers who have been partners in care throughout their loved ones' healthcare journeys as designated partners in care. There is a difference. Visitors are those who visit and who might offer, emotional support or a short visit to come in and see someone who's in hospital. But family caregivers who are designated partners in care have an active role in the care of their loved one. They partner in care, and they have an important space in the healthcare system. In 2014, the Canadian Foundation for Healthcare Improvement, we partnered with the Institute for Patient and Family-Centered Care of the U.S. to spearhead a campaign which we called Better Together. And the goal was to enable patients to designate family members or other caregivers to be their partners in care and to have unrestricted access to them while in hospital. And so in a moment, I will review for you in the next slide the impact that family and caregiver presence has based on the evidence and the research that we have to date. And I'll outline for you the value of patient and family caregivers in a pre-COVID-19 time and then where we are now. First, I want to reflect on our current status and have us reflect again on some of the language that we're using, the restrictions that are in place as a result of the COVID pandemic, and the contingencies that are being put in place by hospitals and healthcare leaders to support family caregivers to continue to partner in care. I mentioned already the distinction between the word visitor and a designated or essential partner in care. And there is an importance there, and it's my hope that throughout this conversation we'll reflect on that and start to revisit the language that we're using as to the role that family and caregivers have in the healthcare system. Of course, in the unprecedented times of COVID-19, the transmission risk and the incredible colleagues who work in infection control and IPAC in hospitals, there has been a very strong restriction policy put in place for anyone visiting a loved one in hospital. And I'm hoping, again, throughout this conversation and with the panelists that we have with us today, we can have a discussion about that in terms of what it's looking like as the crisis unfolds and as the pandemic unfolds, and the more that we're learning, how we can continue to partner with family and caregivers. We're going to talk a little bit about what family caregiver partnership in care looks like and some of the changes that have taken place because of the leadership across the healthcare system. And I know Angela Moore will reflect a little bit on some of the practices, for example, that are in place at Kingston Health Sciences Center. We want to talk a little bit about perhaps how we can recalibrate and introduce strategies to include family and caregivers as essential partners in care, what it might look like to designate specific persons and to take them through an important screening and education process to ensure that they can be safe as they partner in care. And we'll talk a little bit about what those visitor policies can look like in terms of duration of visit, time of visit, and how many visitors. Certainly now is not the time, again, for open visitor policies, but there is an opportunity to talk about that family and caregiver presence in care. And so first a review of some of the evidence and information that we have available to us now and that we have found through our work and our research as a function of Better Together. And if you've had a chance to read the blog that was posted before this webinar took place, I reference in that several sources that talk about the value of family and caregiver presence and the impact it has on the value that we have around patient-centered care. It is evidence-based, and in some instances, it is highly relied upon by clinical teams. Family caregivers reduce medication errors, they help to prevent falls, they reduce patient and family anxiety, they contribute significantly to patient safety. In fact, through the research and evidence, it is shown that the presence of family and caregiver partners help to improve discharge planning and transitions in care and help to decrease readmission. We find that staff are more engaged with their patients. They know more about them. There's improved communication and coordination of care and information sharing, and that reflects positively on staff engagement. We see that care can be individualized, that we see beyond the patient and we understand the person who is in care and who's in that bed. And that is an important part of quality of care, patient experience, and outcomes. And we see a recognition of family caregivers as allies and partners in care and not just a visitor. And if you visit social media often, as I do, you'll see the hashtag not just a visitor being used prominently and regularly, including in this time of COVID. There is a significant challenge to family caregivers who have been active partners in care and who are now facing highly restrictive policies. Leaving a vulnerable loved one at the emergency department or as an inpatient in a time of crisis or with significant and complex health issues is a very significant emotional ask, not just for the family and caregiver, but for the patient as well, who has relied on that partner in care to support them and help them in their time of being a patient. We know that there are feelings of fear, anxiety, and guilt. These are real emotions, and that there is fear and distress for patients. And we know that wave 4, that mental health impact of COVID-19 is coming, and having a plan in place to help mitigate these feelings of fear and anxiety and distress will be incredibly important as we continue with a change in family caregiver presence policies across our hospitals and institutions. There is a question out there is, can we recognize priority populations beyond some of those already identified? Can we look at supportive policies for persons with dementia, altered states of consciousness, patients who are in crisis until stabilized, pediatric patients who are in the midst of transitioning from pediatrics to adult healthcare settings, or for our medically fragile and complex patients? And can we look at applying these practices consistently? So as I mentioned, in 2014, the Canadian Foundation for Healthcare Improvement and IPXCC took on this campaign around Better Together. And what's been really timely is that over the past 4 months, I've led an expert advisory group, some of whom are on this call today, to help us reframe an even more elevated family presence policy and partnership scope. Now, of course, now is not the time for us to launch that type of programming, but what we have done is we revisited the analysis that we did in 2014, and we've taken a snapshot of where we were pre-COVID in a very timely way, and we also took a secondary snapshot of where we are post-COVID. We did this in partnership with Shoshana Hahn-Goldberg and her team at UHN Open Lab to help us do this analysis of where we're at with family and caregiver presence policies. It offers a snapshot of 118 eligible acute care hospitals across all Canadian provinces and territories who were included in that initial review, and we compared them to the previous review, which we did in 2014. Notably, as I mentioned, this review was conducted in January and February of 2020, just some months before the crisis hit, and we had an opportunity to look at it in mid-March when we were in the midst of the crisis. Here are some of the findings. Of the 118 hospitals sampled, we found that those that had accommodation for family and caregiver presence, which means less than 14 hours, were sitting at about 32% in 2015, with an increase of 73% in 2020. Those hospitals or organizations with open family presence, where they had 14 plus hours of time where families and caregivers could be present at bedside with patients, rose from 23% in 2015 to 67% in 2020. Why is this? Well, over the past 5 years, we've seen a significant shift in the importance of patient-centered care, one of the 6 themes of quality outlined by the Institute of Medicine. Other international institutions, such as the Commonwealth Fund, have followed suit, defining high-quality care as that is effective, safe, coordinated, and patient-centered, where patient-centeredness also consists of care delivered with the patient's needs and preferences in mind, and family and caregiver presence. So we've seen that significant shift. What's happened since then? And again, we went back to our colleagues at UHN Open Lab to do a quick analysis of what's happened since the shift of COVID-19, since the COVID-19 crisis. We know that many hospitals have adopted or improved family presence policies, have now suspended or significantly reformed them in the light of the pandemic. The exceptions are end-of-life care, pediatrics, and mothers who are giving birth. We also have seen an application of persons who require a substitute decision maker or who are under the age of 18, but we haven't seen consistent application of that policy. Of the 35, we took a sample of 35 of the 118 hospitals on March 11th, and you'll see now that 91% have new restrictions. We see a change now of 57%. Those who had open, flexible policies are now down to 0, and that's from 20 hospitals surveyed. Again, almost all have had a suspension of visiting, and I'm using air quotes for that, but that does include family and caregiver presence, with very few exceptions. What has been a positive is that this has been very clearly communicated. We see a lot of hashtags out there being very specific that family and caregiver presence at this time is not available. An acute care hospitalization can really be a major event in the lives of patients and their loved ones. And not only are patients clinically vulnerable, they are often mentally and emotionally compromised. The infection control-based decisions and the incredibly good intentions around the COVID-19 pandemic do have impact for patients and families, as I mentioned earlier. And there needs to perhaps be a consideration of the unintended consequences, the patient's safety and patients falling through the cracks, and are we appropriately covering all vulnerable populations? There also has been the mention of the longer-term mental health consequences. At the same time, we've seen some incredibly creative patient and family engagement teams with the rapid emergence of the pandemic and the shifts in policy who have been offering significant opportunities for patients and families to engage through other means. virtual means, including use of iPads and tablets, cell phones and emails, virtual visits. In fact, we've heard from our colleagues at the University Health Network in Toronto, where their ICU team is asking for families and caregivers to engage in ICU virtual rounds. And so we're seeing that incredible leadership occur and hoping to see more of it as we work through these restrictive policies as a result of the pandemic. I'm going to turn it back to Jennifer now and to our incredible panel that we've convened today to discuss this issue of family and caregiver presence further. Thank you so much.
Thanks, Julie, for sharing the results of that research. And thanks for everyone who's also weighing in on the chat. We want to definitely bring in a broad range of voices into this conversation. And Margaret, I'm wondering if I can start with you in terms of how things are changing in New Brunswick and what's your perspective?
Okay, thank you very much, and good afternoon, everyone. Many of you know Horizon Health Network is one of the 2 health authorities within New Brunswick, so we operate 12 facilities that span about 2/3 of our province. So my particular circumstance is unique in that I have responsibility for infection prevention and control as well as patient-centered care. So our executive team, when we first convened our executive leadership team toward the pandemic response, we very much carefully decided what were going to be the restrictions that we placed and where we were going to be able to make some exceptions and have some flexibility. So from our perspective, we are within those groups that have limited family presence to those areas that Julie had mentioned. It is for mothers in active labor, postpartum mothers, and as well for pediatric patients. Additionally, active palliative care patients and our critical care patients. And so within that particular purview, we very much welcomed a support person to come into the facility to utilize the correct personal protective equipment and so forth, and to be able to engage within that individual's care. Alternately, we were also within that health authority group that very much made available to all other patients all of those electronic means for connection. So through telephones, through iPad, through our volunteer services, the Well Wishes program that is available, and so we very much encourage all of that virtual connection that had been mentioned. Additionally, we also recognize there is no way this can be a one-size-fits-all circumstance. And so we also recognize the need for some flexibility for compassionate consideration of specific individual circumstances. So, for example, a son from another province who ostensibly would need to come into New Brunswick and self-isolate for 14 days, but his mother was actively dying. And so we made arrangements for him with the correct personal protective equipment to come in and to be by his mother's side. So a few particular circumstances like that we definitely made arrangements to have that flexibility and compassionate availability as far as possible. Otherwise, I will say that the circumstance has been challenging. We know that there are many patients out there who ideally should have active family presence that we're unable to allow that at this time. However, we also closely monitor the situations on a day-by-day basis. So I'll just stop there.
Thanks so much, Margaret. And if I flip over, you mentioned children in your center. And Alex, I know you guys have been thinking about this hard at CHEO. Can you talk a little bit about where things stand for you and how you're thinking about this issue?
Sure, and thanks for the opportunity to participate. So when the pandemic was declared some 820 days ago, it just feels that way, we weren't getting a lot of guidance from, if I can speak about the Ontario context, we weren't getting a lot of guidance from the center. They were getting organized. And so it's a much more command and control operation from Ontario Health and from Toronto today than it was back at the beginning of March. So at that time, we basically took our existing viral season restrictions and deployed those. And to the distinction that Julie was making in her presentation, We during the viral season restrict visitors, but we don't consider parents and caregivers to be visitors. We consider them to be part of the care team. We do consider siblings to be visitors, and that we recognize is difficult for families. So we simply really pressed into service, probably with a little tighter enforcement than we normally would. Our existing viral season policies, which would be one parent and caregiver in the emergency department or outpatient clinics, and two on the inpatient units, two designated on the inpatient units with one in the room at any given time. And then we put a whole series of supports in place to help parents and caregivers, and that includes escorts through the building, iPads and electronic devices, food delivery, medication delivery to the room, to try to make life easier, but also limit the amount of people that are moving around the building, because this is a period of infection prevention control. We also obviously, as Margaret outlined, will make exception for compassionate circumstance. We're not, under no circumstance will a child die alone at jail. That can't happen. So we have had situations in our NICU, in intensive care, and of course we work in close partnership with Roger Nielsen House, which is pediatric palliative care hospice on the grounds of CHEO, that have the same restrictions as we do in general at this period, but obviously all of us will make compassionate exception. And this really is about parent-caregiver presence. The other part is really about parent-caregiver voice, because, and I think Julie outlined well that parents and caregivers bring expertise to the table, and they bring important advocacy to the table for their child. They also help. And, Ontario has fewer acute care hospital beds than any jurisdiction in the Western world, and lower levels of staffing. And compared to long-term care in other sectors, we're much better staffed. So I can only imagine what it's like in those settings, but I know that in our setting, we need to help families to care for patients, and as well as their insight, their expertise, their advocacy. We need their arms and legs and actual physical help to make sure the patients are cared for. And so, we acknowledge that and respect that, and that is part of why we say parents are part of the care team, parents and caregivers. And I would say lastly, and maybe we can talk about that later in the webinar today, we have, because we're moving at the speed of COVID, we have in all of our processes, our incident management team and family representation. I see one of them is on this on this webinar. Our work groups do, our communications are read to them. So we are trying to manage the crisis with the voice of parents and families as we make these breakneck or decisions rather at a breakneck pace.
Thank you, Julie. I was on mute, like everybody else. That's the defining feature, I think, of the need to put yourself off mute. But I was just saying, I really appreciate the fact, Alex, that you brought so many different dimensions to the fore: the dimension of presence, the dimension of care, the dimension of voice, all of which are important, and I hope we can come back to, because I think there's some interesting learnings on all of those fronts. But before we do that, Angela, I want to bring you into the conversation as well. Obviously in Kingston, you're looking at a full range of age ranges. but also a different role that you're in. So can you talk about how you're thinking about the challenges now?
Sure. Thanks, Jennifer. And I really relate to a lot of what I've already heard. And Julie, your presentation at the beginning definitely gave us that nice context. And so I think what really stands out for me is that piece around the dimensions and patient and family-centered care, people and family-centered care, and what that means in an organization. And what I see here is a commitment for that to be a part of what's driving our decision-making at every table. And so very early on in the COVID experience, at one of our Patient Family Advisory Council meetings, our senior VP attended the meeting and said, this is on the horizon, and if this unfolds the way we're thinking it's going to unfold, here are some of the things we're going to face. And we are going to need your perspective to see how to address that, because some of these things are going to be taken out of our hands. Some of these things are going to be mandated by the province, and we are going to have to act quickly. And so we, very early on as an organization, there was transparency around what was coming, what the challenges around that might look like, and a discussion about how we might stay involved in that. And I think that made a really big difference as we moved forward, because there were then just conversations about, okay, the chances are we're going to have to limit family presence in our organization. Family presence is a keystone, fundamental principle of this organization. That change was big for families, it was big for patients, and it was also big for staff and leaders who are used to welcoming families, who are used to partnering with families, and they don't like this feeling at all of the families not being there. And so there was a lot that had to be communicated about what are we going to do when we are in this situation? What are the things we can do to support our families and our patients? How are we going to address this? Not just say, okay, that's the way it is, but actually say, okay, but what are we going to do about it? And so we really engaged our patient advisors, our patients and families, but we also have been pretty open to listening, I think, to staff who have really amazing insights into what families and patients are experiencing on the front line, and that is unique to this situation. And they have a voice to come forward to what we call incident command, so a table that is making those sort of final decisions, and they have a voice at different tables within the organization as staff to say, this is a real concern for us, how could we address it? And we're seeing some major changes really quickly because of some of those things. And then we have patient advisors sitting at some of those tables, like the task force tables and the clinical table that provides recommendations to the incident command, and they are able to have a line of sight into everything that's going on in the organization. We share all of the updates that we give to staff with all of our patient advisors by email. That transparency about what is going on and the challenges and how fast things are changing has created, I think, a sense of trust and a sense of we're in it together. We need to find the best ways to do this. And it's front of mind for everyone as they are looking at the policy changes that have to happen. So, for example, when we say, okay, we are now saying that only essential visitors can come in, there needs to be a whole discussion about what is that and what does that look like and how do we articulate that to families who walk in the door thinking they're going to be able to go with their loved one to an appointment, and how do we streamline that whole
process so that it's easier for everyone. The people on the front door, the screeners were upset about having to do it. The families were upset about arriving and finding that out. So there was a whole communication that had to happen around that. And then there was what is the support we're giving to the families when we turn them away, and what can that look like? And so we have been doing a constant sort of reevaluation, addressing things as they come up, and engaging our patient partners in helping us to do that as we proceed.
Thanks so much, Angela. And I might just pick up on that last set of points that you made and then throw it back, I think, first to Margaret and then to Alex. And it is this question about how have patient partners been involved in helping to influence some of the procedures, some of the processes, bringing that voice to some of the big questions that we're all facing right now and that we will continue to face. And I know there's been, out in BC, for instance, Patient Voices Network has been involved in some decisions there. There's been a bit in Quebec as well in terms of involvement in the research agenda and in the care agenda. Margaret, I'm wondering if you can talk a little bit about in your context that the importance of that voice and how you've seen that playing out.
Well, I will say we've had a very good liaison with the person who is our co-chair of the Patient Advisory Council. He has himself a background in healthcare, and so he's been really invaluable in terms of helping to lead some of these discussions and really understanding things from, I will say, a few perspectives. So we really relied on him to assist us when we were, developing these policies, and also the communications out to the community about what were going to be, unfortunately, some restrictions in family presence. Otherwise than that, I will say that with the exception of some emails to our Patient Advisory Council, we really haven't engaged directly with our patient advisors over the last 2 or 3 weeks. Unfortunately, because of all of the committees disbanding temporarily and so forth, we have not continued to have them come into our facilities. However, through our coordinators, we have continued to liaise, to respond to questions, to really try to reassure individuals about what we are hoping to be a compassionate and, I will say, flexible process that we have introduced, and to respond as quickly as we can when questions arise, both from members of the public, from families, as well as from our patient advisors and those on our patient council. So that's really how we've proceeded, at least in the medium term, and we're hoping to convene our patient council at a meeting via Skype very soon to be able to engage in broader discussion and share a bit of the experience to date.
Great, thanks, Margaret. And Alice, I'll toss it to you now with a little riff, actually, because there was a question that came in the chat box that I'll add to yours that was specifically for you, which is both about the opportunities for voice within CHEO and the work that you're doing, but also how might that influence broader policies and the work that you might do with your colleagues in pediatric centers or at the province in general.
So thanks for that. So here's what we've done since the pandemic declaration, just around our pandemic response as it relates to family voice. So we struck an incident management team that meets up until now, meeting every day, and we have family representatives on that. There's 3 different individuals who share that load because that's quite a time commitment. We've been doing virtual town hall meetings with families. The next one is tomorrow to answer any questions they have and to get their feedback. And we've also included family reps in a number of the working groups that are being established underneath the structure of our incident management team to deliver on various aspects of that. So, for example, we struck a group around community operations, and so that's the work that we're doing really for kids and families infected or affected by COVID in the community. A lot of that work being done with our Kids Come First Health Team partners, where we have family representation throughout that structure as well. So as we're doing the planning for our response, we're trying, even though we're going very, very fast, we're trying to make sure that family voice is included there, And then there's all kinds of ad hoc engagement, whether it's consulting families about the communications that needs to go out about some of the changes, or even just using social media. Social media, very useful for collecting ideas, getting feedback, and hearing from families about what's on their minds and concerns that they have. In terms of a broader question of affecting the provincial picture, interesting question. We are in Ontario, because that's what I know. We are in a command and control environment. Certainly the children's hospitals, the three freestanding, and then the two Hamilton and London children's hospitals, the five of us working together. So, for example, last week on the issue of access to the assisted devices program, which has been slowed down as a result of some of the changes in the Ontario government, and doing advocacy around that. And so we have, we're very tightly connected as 5 out of 150 hospitals. And so we've certainly stayed in communication, shared material, shared ideas, and done some advocacy. But I would say, generally speaking, it's a relatively top-down command and control type of environment in this emergency, as the government seeks to really move on a dime and respond to whatever the latest crisis is. There's a regional structure here in our region that does not have significant family voice. It's kind of the tier down from the provincial response. I think the question now will be, that's fine, I suppose, for 4 weeks or 6 weeks or 7 weeks. But if we succeed, remember everybody, flattening the curve doesn't mean we have fewer COVID cases than hard-hit jurisdictions. It just means we stretch them out over a longer period of time. And so if we're going to live with COVID for some time and be kind of in a half COVID, half not COVID state, then we'll need different structures to manage some of this decision making. And then the last thing I would say is, in terms of the patient and family advocacy that we're definitely hearing on the acute care side, is the ramp down, the cancellation of elective procedures, surgeries, clinic appointments, and from a child health perspective, again, a month is a month. They can manage that. But the longer that goes on, you're going to start to have serious impacts on children's health and children's development. And we're feeling the pressure and relaying the pressure that we're hearing from families about figuring out ways to start to ramp up the delivery of care again. We've seen, again, talking about the Chile, two-thirds acute care, one-third community-based care. If I look at the acute care side, we have seen a 30% decrease in, for example, kids with diabetes in the emergency department. We've seen a reduction in the number of cancer diagnoses in the emergency department. There isn't less diabetes and there isn't less cancer as a result of COVID. So that's people staying away. And that's a concern for us as well.
Certainly an area we're hearing about from a lot of parts of the country, and something that may well be the subject of a future Spotlight series webinar, because it's such an important issue. I've been monitoring some of the questions that have come in, and there's been a number of questions around the how. So how are you using technology effectively to support virtual rounds, for example, to support connections with patients and families? How are some of those working? So I wonder if I can do a speed round of each of you. One thing that you see that's working really well that might be an insight that you could share, and one thing maybe that's an even better if, something you're working on, something that you'd like to see moving forward. Angela, do you want to start us off?
I think our virtual visits between patients and their families has been a success story in that we have provided instruction on how to do that themselves with their own devices, but we have also managed to round up a whole bunch of devices to be able to share for those who don't have them. We've created a process around it that meets the infection prevention work. We've created support for people to do that. So I think that piece is really great and it's important to people. We had one patient who just said it was just so nice to see her dogs. And, there's those little things that just make everything a little bit better when you're alone. I think the piece that we are currently working on and very excited about working on, we've got the e-visit piece in place between a physician and a patient. We're looking at how are we engaging families in those visits. What are the privacy issues around that and the consent issues around that? What is the platform that we can use on that? So for a patient who can just sort of put their family on FaceTime, that's one thing. But if we are looking at having those conversations, clinical conversations with families on a more regular basis and rounding, we're creating that process now and looking at the technology around that. So huge kudos to our IT teams who just have been pumping out new technology to support us being able to really reinforce that partnering.
Thanks so much, Angela. So I'll transfer it over to Margaret next. As I do, I would invite those on the phone. If you've got ideas about things that are working well in your context or even better, feel free to put them in the chat as well. Expand the conversation as some are doing. But Margaret, over to you.
Okay, thank you very much, Jennifer. We've also been very fortunate that we've had very good success in leveraging technology. Already within all of our facilities, we had free Wi-Fi access available to patients and their families. So it was very straightforward for any patient or family member to have brought in an iPad or any other type of a tablet device to be able to utilize very easily to have that type of one-on-one conversation. Additionally, for those patients that did not have telephone access, we were able to arrange for that. We've also been able to arrange with providers to defer all long-distance charges so that that wouldn't be any financial impediment to anyone connecting. Additionally, through our telehealth program, we have been able to make arrangements for those virtual consultations to include a family member with the physician and patients as required. So that's been, I believe, successfully organized, and I haven't heard of challenges with that. And as well through our patient representative services, we have ensured that the availability for those family consultation meetings to continue to occur, whether they are via Skype or Zoom or by just teleconference, that those consultations and family meetings can take place virtually rather than in person. But they've definitely been really important, and the patient representatives have been really integral to ensuring those loops are all closed and that everyone keeps as well informed as possible. So overall, I will say there have been a few snags, but fortunately few. I believe for the most part, family members have felt comfortable with the electronic and virtual systems that we've had available.
Thanks, Margaret. Alex?
It's all that different here. I do think, from my perspective, we were moving at much too slow a pace on virtual care, so this has lit a big, huge fire under all our bums, and we're finally doing the things we should have been doing all along. But anyway, here we go. And so big expansion of virtual care. And in some parts of the organization, mental health basically, the outpatient mental health area has zero decline in productivity. They just moved all of their activity into virtual care. Just hearing on the weekend, our nurse practitioner in our ENT clinic, whose caseload is kids sleep disordered, is seeing the same number of kids now as virtually as she was in person prior to March 13th. And we're increasing that all the time, using iPads, handing out iPads and to families that don't have them in order to be able to expedite social connection. All of those kinds of things that you've heard from Angela and Margaret, I think those are happening in every organization, and I don't think we'll ever go back. So I think this is a silver lining to this crisis. This is progress that we've made, and we're also learning what works, what doesn't, the supports we need to put in place. We've made work from home mandatory for those for whom it's possible. So that will probably also solve our space crunch at CHEO when we pull out of this. So I think that is what's worked well. What do we need to do better on? I would say we need to have more proactive outreach to, and it's connected to people being scared to come to hospital and the ramp down of so-called elective activity. We need to do more proactive outreach with our oncology families, our complex care families, those that have an ongoing relationship. Some of that's been happening. It's been uneven, and as the crisis extends, that's something we've heard from those families that is important, and so that's we got to pull up our socks on that one.
Thank you, Julie. Just jumping off on Alex's last point, there were a number of comments in the chat related to the point that you just made around people who may not be receiving care right now, either because they're worried about coming into a healthcare institution or because services have been paused given the COVID situation. Thoughts that you might have around what some of the priorities might be that you're hearing from patients and families, ways of managing that going forward. Margaret, you mentioned this early on and some of the sort of things that you guys are doing. Do you want to say a few more words on that front?
Well, certainly, I think just in follow-up to what Alex had said, we are hearing now from patients and some of their family members concerns, particularly about the suspension of surgery. And so that is something that we're looking at now very seriously. There's already a plan in progress toward how we would be de-escalating those concerns and re-engaging again with surgical care, particularly for some fairly urgent elective surgeries. So that's been one concern. Aside from that, for our ambulatory care visits, if possible, we have been organizing those virtually. However, all cannot take place virtually. So looking at a safe, sustainable way for us to gradually ramp back up some of those ambulatory visits that are required. Although I will say that for our patients who are seriously at risk, such as our oncology patients, we have for those ambulatory visits continued, of course, to allow them and with a support person. And so we know that that has been working well. The support individuals, those people who come with those fragile patients, our dialysis patients would be another group. They want as much as we do to ensure everyone is safe and that, of course, infection prevention is as maintained as far as possible. So we found the collaboration has been very, very good. So we're really hopeful with the correct guidelines and education that once we ramp back up and start to de-escalate some of our precautions with regard to presence in our facilities, that we'll be able to have an appropriate level of engagement with that.
Thanks, Margaret. Angela, and then Julie?
Yeah, I think that there's ongoing concern about are people getting the care that they need? Are we communicating out that they can get that care and that it's safe care? So I think there's going to be a lot of focus on that. I think as we watch things unfold in long-term care, there's such a huge tie between long-term care and our hospitals, and how are we supporting each other as we move forward, I think is going to be a real priority. I think for patients and families, it's really about how are we slowly going to move things forward, and how are we ensuring that their perspective and what's important to them is being considered as we make those policy decisions. And I think there's some work that could be done in ensuring that at a provincial level where the mandates are coming down, that those voices are being heard.
Really?
Yeah, I mean, there are certainly a lot of questions out there by patients, families, and caregivers about access right now, and we've seen several examples across the country where lack of access is creating harm and potential harm. And so I think we have sitting at our doorstep right now a problem, and I'm hoping that the powers that be are on top of that problem and starting to address it. It's not just the concern of people coming to hospital for fear of COVID-19 and exposure. It actually is a reduction in services. It's a reduction in surgeries, it's a reduction in diagnostics, it's a reduction of interventions, and it's people who are going to experience harm if they have not already because of that lack of access. So I think the time is now to be addressing that. The other thing, too, is I want to reflect on some of the questions that are coming up in the chat box that are been specifically directed towards me, and apologies because it's really small print. But some people are asking very specifically about, are we measuring the harm or the patient safety consequences of not having family and caregiver presence at bedside? As Alex alluded to, you know, families aren't just there to visit. They're actually active partners in care. They perform hygiene, they do ambulation, they do medication oversight, they help to communicate and coordinate around care. In the case of pediatrics, many parents are well versed in suctioning and G-tube feeds and central line access, and can sometimes do it better than the nurses because they do it frequently and often. And so what kind of risk are we putting patients at, and is anyone looking at that risk and providing that feedback back to the ministries as we evolve through the crisis? So that's one question and comment. The other that I just want to clarify for many who are asking you the question, from the outset I talked about visitors and family caregivers. So family caregivers can be friends as well, or they could be designated caregivers by the patient. It's not just a blood relative. So I want to be very clear about that. The second question was, well, aren't visitors as important? Are we creating a hierarchy? At this time, in a time of COVID-19, no, visitors aren't as important. But families who are designated as essential partners in care, 1 to 2 individuals, and Alex articulated a really strong outline for a policy that he has in his hospital, yes, that is what's appropriate right now for specific patient populations. And again, I would argue that we've got to move beyond the patient populations that we've already identified and think about a few more where there would be high value around patient safety and patient outcome if they had a designated family member at bedside. And there are a lot of questions about, will those family members be provided PPE? And we all know that the PPE shortages, so I can't answer that. I'm not in a position. But certainly, you know, the hope would be that there be consideration around that, if not around education and training about effective infection control policies for families and what they can be doing to protect themselves, their loved ones, and the healthcare workers. I'll tell you, families are hella good at hand washing, probably beyond anybody else. But we can give them appropriate information about how to do that effectively.
Thanks, Julie. And this hour has flown by, and there's lots of other thoughts and comments in the chat box. Really appreciate those who've been answering other people's questions as well in the chat box, which is great. And we will be trying to close the loop on some of the other questions as well. But I'm going to do a really rapid speed round. One thought to leave you with. Angela, do you want to start us off?
Just know, I think that everyone is really trying hard to do their best with the information they have when they have it. Know that your loved ones are safe. Know that the care is there.
Thanks, Angela. Alex?
I think the system will never be the same, and so we need to make sure that the way the system changes is one that's positive for patients and families.
Thank you. And Margaret?
Just add that this situation is certainly unprecedented in most of our careers. However, I will say the groundwork that many of our organizations have done to create our family presence policies, to establish our patient advisory councils and introduce our patient advisors has been extremely helpful to really sensitize all of our staff members and decision makers toward their needs, and hopefully to allow the flexibility and compassionate care delivery.
Thank you so much. Julie, last 30 seconds to you.
Yeah, I'll just say that let's keep a conversation going. We're all learning right now in the time of pandemic and crisis, and the questions aren't harmful or hurtful or finger pointing. They're really important to the ongoing conversation and making sure we're doing the best we can in this time. And thank you to everyone who's been involved in this.
Absolutely. Huge thank you to everyone for participating today. Un grand merci. And to Alex's point, hopefully together we can continue this conversation towards the future that we all want to see. Thank you so much for joining us today. We will be posting the video as well as the slides, and we'll endeavor to follow up on some of the additional questions as well. Thank you, everyone.